All right, this week's webinar went over cardio poems, so I'm just going to go through my notes real quick. We went through the heart anatomy, flow of the heart, valves, chambers, all that good stuff. I'm not going to name them out. Then the cardiac cycle. I'm not going to talk about that either. Systolic, dystolic, and then all that stuff. Dystally, where the heart's relaxed and refilling, and systole, where it's contracting. More cardiac cycle. We went to EKG, so the PQRS complex and T wave and all the good stuff that goes with that. Atrial depolarization, repolarization, ventricle depolarization, and all the stuff in between. Next, still more EKG stuff. I did really like this chart that they had. Kind of just had a nice chart of showing at like the P wave, you have your normal height, and then if it's increased or decreased, increased, you have your myocardial infarction. If it's depressed, then you have some ischemia going on, and it just went down. It was just a nice little chart, so I did really enjoy that. Some more EKG squigglies showing J points and stuff. And then kind of went through the ST segment, more ST segment stuff, horizontal depression and downsloping of the ST segment. Talked about all that stuff. Then they went over bi and trigeminy EKG abnormalities. If I remember right, that is, consistent with like a heart, PVC. So, yep, you have your inverted, and you have your two QRS complexes and stuff like that. And then we went through the what's the word I'm looking for? The electrical flow of the heart, SA node, pacemaker. I did really like how she explains the heart block here, where the AV node kind of distributes the impulse to both the left and right ventricle, which I guess I didn't really realize up to this point, but she explained it nice, and it really made the heart blocks a little more clear to me, because I was a little confused on that stuff. So I did like that. That made it nice and clear. Structure of the nerves, not going to go into that. Keep on going down. More heart block stuff, just talking about the flow, the impulse, the direction of it, and all that good stuff. And then they talked about first degree, second degree. In this video, they said don't worry about like the two different, the Morbiz or the Wenckebach. I don't even know how to say it, but either way, just I think she was saying just know kind of what they are, and she did have like a nice little kind of like rhymes to remember them. So like it's like if R is far from P, then you have first degree. So that because that's kind of it's a lot of memorization. So that was like a nice one to remember, that first degree heart block. The second degree was longer. Then it's Wenckebach. So it's like you just have a long, nothing happening, isoelectric on that EKG. Let's go down. Normal response to exercise. Kind of obvious stuff. Just normal response to exercise we went over. I did like she kind of pointed out, and I think I have heard this before, but so for every MET you go up, it goes up 8 to 12 beats. So your heart rate will go up, should be going linear with the MET increase during workload. Going up 8 to 12 beats per MET, which is a nice, I guess, information. Then you have your abnormal responses, so like heart rate. Obviously, if it's dropping or it's going up, not really linear with the workload, then you got a problem. Blood pressure, obviously you don't want this diastolic going up at all, or if it does, no more than like 10 millimeters of mercury, mmHg. And systolic, again, kind of linear with exercise to a point. If you get to like over 200, over 100, 110, probably got a problem, and you never want it to drop. If you're exercising and your systolic blood pressure is going down, bad news. Stop exercise and do all the things. Breath, muscular fatigue. I did like how she explained your blood pressures are different in your upper extremities, your upper body and your lower body, and it pretty much came down to you're gonna have higher blood pressure in the upper body because they're smaller muscles. And it's just like more muscles. It's also higher, what was she saying? Higher ratio of type 2 fibers, and type 2 fibers fatigue quicker. Yeah, kind of rambled over myself on that one, but we're all good. We'll keep going. Cardiac rehabilitation. So always the part that I always end up slacking on because I'm like fatigued from learning all this stuff, and then we actually get to what we're supposed to do. But pretty much just looking out for anything that is not right when you're doing cardiac rehabilitation. Watch out for any medications, heart beta blockers. Can't take the heart rate for kind of see where their exertion's at. You got to use the Borg scale. Oh yeah, and speaking of the Borg scale, she talked about it, and I never knew why the Borg scale started at 6 and went to 20. I was like, that's random, but she made it make sense. So if you have like because it correlates to heart rate. So if you have you're at a 12 on the Borg scale, you multiply it by 10, gives you you're about 120 beats per minute. So that I literally have known about the Borg scale for 15, 20 years and never knew that. I just memorized it and went about my business and then never actually really used it. All right, going down, measuring intensity, the old max heart rate, 220 minus your age, and then you have your heart rate reserve, max heart rate minus resting heart rate. Yeah, percentages. In cardiac rehab, you kind of want to stick into that like 65 to 85% of your heart rate max. METs, 5 to 9 METs, which is equivalent to about 11 to 15. I think we were always talking about 11 to 14 in class. So hopefully nothing's that close. And then we had like the whole Borg scale paired up. It was like a chart paired up with the Borg scale, the modified RPE, breathing exertion, and heart rate max. So it kind of like had a nice chart of all those and how they like correlate with each other. And then more cardiac rehab, you have like your inpatient, immediate, a couple days post heart attack or whatever, kind of sticking in that 4 to 6 MET range. I think you don't really want any more than like a 10 to 20 beat per minute increase. And then they talked about outpatient, where you're bumping things up a little bit. You're at about 11 to 13 RPE, kind of like 5 to 9 METs. And then your community program, that's pretty much once they're discharged and they get to go out and get their Silver Sneakers membership and just hit that elliptical. All right, then we went over lines and tubes. Some of them look familiar. I had the pleasantries of dealing with a lot of these when I was working in a SNF. Fun stuff. All right, on to some questions. Then we asked a bunch of questions. I did like this thing. So I've never heard of the Point Wells scale, and this is to identify pulmonary embolism. So it's pretty much like a scoring. So it's like clinical signs of DVT is like a 3, and then you have like if your heart rate's over 100, blah, blah, blah. You go down the list. I think there's 1, 2, 3, 4, 5, 6 criteria. And if you score 4 or less, you're not unlikely. It's unlikely a pulmonary embolism. But either way, I can never remember scales, but I feel like it could be a helpful scale. More questions. Pulmonary system. So just all like your volumes, and then she correlated it to like COPD, like your heart rate reserve is going to be increased with COPD because you can't exhale. And what are those? Functional capacity, and I'm spacing the other capacity that involves, if it's in the mathematical equation of respiratory reserve, it's going to be increased. Everything else is going to be the same or decreased. And then restricted diseases, pretty much everything, all your pulmonary functions just all get smaller because you can't get air in. Postural drainage, which is again one of my favorite subjects. Just kind of, but she did break down for the postural drainage technique. She did break down like the different positions pretty nice. Had like a couple little mnemonics. I actually don't have I didn't take notes on it, but I'm gonna go back and, because it was a little too much to write down, I'm gonna go back and look at that. But yeah, she did have a nice way of breaking it down, remembering all those 9 different positions for postural drainage. All right, and then obstructive rehab, some more lung stuff, so just more cardiopulmonary, more questions, and then breathing patterns. These are a little foreign to me with like, but yeah, so we went over some breathing patterns. She just went over it real quick. She said she's gonna go back over it. You can go back over and look at it. All right, and then we had some scenario stuff, some more questions, and that's what will do it. So that was the webinar on cardiopulmonary. Thank you.